Hi, everyone. I hope everybody is enjoying the conference so far. We are on to our second panel starting very, very shortly, just in a few minutes. But I do want to tell all of our attendees that are here today to follow us on Twitter at LascUMCP and to use the hashtag Disruption 2021 or Disruption Conference. So join us in the conversation there. We are also live streaming on Facebook on our Lasc UMD Facebook page. So you're allowed to, not allowed, but you can also comment there and we will take a look shortly after we're going through the presentations. But today I will be one of the co-moderators. My name's Nohely, and Lisa will be our other co-moderator, and she will be joining. So I will welcome everybody and introduce the presenters, and Lisa will take note of the time and let you all know when you have 5 minutes left, and then 2 minutes, and then 10 seconds. No, just kidding. But just welcome and thank you so much for being here today. But I guess we can get started. What do you think, Lisa?
Sounds great. I'm looking forward to it.
Yay. All right. So today we have 4 presenters, 4 women. So yay, that's amazing. We will hear from Irazábal de Sanchez. She is a licensed clinical social worker and current doctoral student who seeks to understand how we can decolonize psychotherapeutic practices to best serve marginalized communities and individuals. Second, we will hear from Valeria Garrido, originally from Ecuador. She's a graduate student of the Latin American Studies program at Ohio University and currently works as a graduate assistant in the Infections and Tropical Disease Institute at OU. Next, we'll hear from Samantha Primiano, who is a PhD candidate in anthropology here at UMD, where her research is in medical anthropology and focuses on mechanisms of care, chronic precarity, and experiences living with chronic illnesses in Havana, Cuba. And lastly, we will hear from Emilia Guevara, who's a PhD candidate in anthropology at UMD as well. Her current dissertation research focuses on local understandings and cultural variability of illness prevention, causality and accessibility of treatment among migrant Mexican women in Hidalgo, Mexico, and Maryland, right here in this very state where we're at. So welcome everybody, and remember Twitter, LascUMCP, and hashtag Disruption 2021 or Disruption Conference. And remember, this is our first day. We will also be having day 2 tomorrow, so stay tuned and please come back. And we will hear first from Irazábal.
All right, thank you so much, Nohely. Do I share my screen for the slides? Okay, let me go ahead.
You should have be able to let us know if you can do it.
All right, so I'll be starting right now. So as Nohely warmly mentioned, my name is Irazábal de Sanchez. I am a white dissenting cisgender Latina immigrant from Caracas, Venezuela, and a proud mother of a 5-month-old who you may hear cheering me on in the background, FYI. So I am, I'll be discussing with you the current mental health crisis that we're facing in the United States, how it impacts our Latinx communities, discuss 3 vignettes that I have put together based on my 10 years of practice in the field to really highlight the barriers and issues when providing psychotherapeutic interventions for Latinos and Latinx communities, but primarily also immigrants. And then propose a decolonial framework that will assist mental health practitioners like myself to better serve these needs. So it's no secret that we're currently facing a mental health crisis in the United States. And the pandemic has significantly increased stress on many, if not everyone, residing in the US. A poll conducted last year on behalf of the American Psychiatric Association found that nearly 80% of adults said that coronavirus pandemic was a significant source of stress, and 60% of adults mention that they're facing overwhelming situations at this time due to the pandemic. And the Latinx community shows similar vulnerabilities to mental illness as the general population. And they face disparities in both access and quality of treatment. This inequality puts these communities at high risk for more severe and persistent forms of mental health conditions, because without treatment, mental health conditions often worsen. So you see in the slide, there's 18.3% of the US population is estimated to be Latino or Hispanic. 16% of those is reported to have mental illness in the past year. That's about 10 million individuals. It's more than the number of people living in New York City at this time. However, a study conducted in 2018 found that nearly 60% of Latinx young adults and 40% of Latinx adults with serious mental health illness do not receive psychiatric treatment in the United States. And this is not mentioning that about 90% of Latinx in the United States over the age of 12 who have substance use issues and disorders did not receive treatment in the US. So these are staggering numbers highlighting the serious need to be able to provide such services to the Latinx communities here in the US. So poor communication, many studies have outlined that poor communication has been kind of the primary reason why Latinx people in the Latinx communities fail to seek treatment or fall out of treatment very quickly. And poor communication could be understood by differences in epistemology, so ways of knowing, ontologies, ways of interacting with the world, and axiologies, the way individuals or where individuals place value on certain things between the Latinx culture and their country of origin to the United States. So often Latinx individuals need to broker such differences and find themselves at odds with one another, naturally producing conflict and ultimately contributing to poor access and low retention of individuals in our current mental health system. So this places clinical social workers in an ideal situation to address the need because clinical social workers are the most abundant of mental health providers in the United States. Not to mention, it's one of the few of the mental health providers that really have a foundation of values around social justice, importance of human relationship, competence and service, and dignity and worth of a person that really highlight the values that speak loudly to the Latinx community. But are we currently meeting the Latinx community's need for mental health services, especially when nearly 70% of all master and doctoral level social works in the United States identify as white practitioners and have different ways of being, valuing, and interacting with the world? I encourage you to explore this question with me as we discuss the following 3 vignettes. So I would like for you to meet Rayo Loti. He is a Mexican, he's a recently immigrated Mexican from a rural town outside of Mexico City. Currently seeking assistance from a community mental health clinic for his child who is being bullied at school for identifying as transgender. He received this referral from the school counselor who strongly encouraged Irazábal to attend a community mental health clinic to access services for his child who is being bullied. So Irazábal is giving an intake packet that he must complete prior to scheduling an evaluation for his daughter. The intake coordinator at the clinic, learning that he is recently immigrated from Mexico, provides him with an intake packet with a whole bunch of scales and information and questions in Spanish, failing to acknowledge Trayoloti's indigenous background and understanding that his native language is Quechua and has low, if any, literacy proficiency in Spanish. So with limited English and Spanish literacy proficiency, he is unable to complete the intake packet to schedule this appointment for the daughter. However, he is extremely respectful of the intake coordinator's time, thanks her, does not ask or request help around this language barrier, and leaves the clinic with the packet without plans of returning or seeking services elsewhere. Next, we have Ramona, who is an Afro-Latina who recently immigrated from Santo Domingo, Dominican Republic to New York City, Washington Heights neighborhood. Ramona, after being pushed by her friends in the community to seek support, she attends a health clinic to really access help around her ataques de pánico, which could be understood as panic attacks in English. She is so stressed and overwhelmed because of her immigrant integration challenges, being underemployed at an informal job, being unauthorized in the United States, constantly being threatened or feeling threatened by potential detention or deportation, and living in a community where she's constantly facing strong machismo in her community. So Ramona meets with a provider who's doing the intake evaluation and is asked as protocol about her drug and alcohol consumption. Ramona kindly and warmly says that she has a cervecita, which is one beer a night after long, stressful days at work. This triggers the clinician to ask questions around her alcohol and drug use, taking up all the time of the evaluation, dismissing her initial request of seeking support around ataques de pánico, and then provides a URL to Ramona that gives Ramona information of alcohol and drug use services. So Ramona, very disillusioned and with no computer at home and low computer literacy and feelings of shame. Also, it decides not to pursue mental health services or attend any other clinic or provider to around her ataques de pánico and help. And then we have David, who is a white presenting Puerto Rican, who was forced to emigrate from Puerto Rico after losing his home from a recent hurricane. He's overwhelmed with the pressure of providing for his loved ones on the island. That often leads him to feel paralyzed to take action, and also living with extended family members, 5 to be exact, in a 1-bedroom, that are renting out a 1-bedroom apartment and a 2-bedroom apartment in New York City. So all 5 family members sharing that one room. So David seeks support and starts weekly therapy. The clinician requests David to find space for himself to practice prescribed meditation practices that require silence and required solitude, failing to understand that David, again, spends the majority of his time in the subway system in New York City, commuting between his 3 jobs, and the rest of the time he is spending in an apartment where there is no sense of privacy. David also shares that he prays to his Virgencita, and the clinician fails to acknowledge that as a form of mindfulness practice and strength, resulting in David just feeling like he's unable to really meet the needs required by the therapist, and drops out of therapy and no longer seeks support and tries to manage it in different ways. So what are the issues and what's happening in these vignettes, and really trying to understand and analyze our current practice? We see that these cases highlight how individualism, multiculturalism, our culture of over-pathologizing non-white individuals, and the use of our evidence-based manualisms contribute to poor access and retention of mental health services in our Latinx community today. Individualism is defined as a philosophy and way of living that prioritizes as individual over a community. Most Western cultures are individualistic. This is a colonial ideology that has been used in the development of psychiatric tools, measurements, and treatments in the United States. This is at clear contrast to most of the global South and indigenous cultures who are collectivistic, as they hold principles that prioritize the need of community and the interconnectedness of people within a group over the individual. So we see this play out in case of David, who his priority, he places his value in really helping both his family in the island, but also where he's currently living in New York City, over his individual need of finding space and time for himself, and that's not really valued in the course of treatment that he was engaged in. And when it comes to multiculturalism, many, if not all, mental health trainings offer training that provides multicultural practices, really with the goal of providing the clinician to become culturally competent. However, as one argues in his article, cultural competence may be viewed as new racism due to promoting an absolute view of culture by otherizing non-whites and deploying a modernist and absolutist view on culture. So we see this play out in Trayotori's case, right, where the clinician and the clinic may have viewed themselves as being culturally competent by having all their measurements and maybe even Spanish-speaking clinicians on site. However, they really missed who Trayotori is and his identity and needs.
1 minute left.
So also over pathologizing, we see it play out in the 3 cases, and evidence-based manualism by having a very rigid way we do treatment. For example, in Ramona's case, how it just steered specifically to substance use, where we don't have the ability to be flexible, could really hinder and hurt our communities and further marginalize them. So where do we go from here? What I'm proposing is really we push in our training and clinicians to really incorporate more relationality instead of historically how our profession has really been very individualistic as a clinician other than the individual, but really develop a relationship with the client. Know that there's 2 people in the room. Also develop or incorporate interculturalism versus multiculturalism in our practice. And what I call evidence-based Taylorism, which is evidence-based is important, and we need to have flexibility to pick and choose from what we have found to be evidence-based to meet the needs of the individual. Some work has been done in terms of finding common factors, and there's a lot more to be done and also introduced in schools because many new practitioners are not aware of this work. All to humanize the people that we work with and stay away from the over pathologizing of them, and really work towards the decolonization of mental health practices in the US. So to conclude, we have a crisis. In order to address this crisis, there's a need to decolonize mental health practices, but also in clinical social work, we could start there. Such decolonization needs to happen along these 4 axes of transformation. And this transformation requires reflective practice and ongoing work. So it never ends. So we need to also kind of have our practitioners be aware of that. The training never ends. Thank you. I'll stop sharing.
Thank you so much, Valeria. Are you ready to go next? All right, whenever you're ready.
Yeah, I'll just try to share my screen. Are you able to see it now?
Yes.
Okay. I think my presentation is very in turn with Anna's ones, because I studied perceptions of traditional medicine in Ecuador, basically to challenge the way Western medicine works in my country. So it is important to know first that 80% of the world's population use traditional medicine as their primarily healthcare system, but Western medicine is considered to be the mainstream approach. This is problematic because traditional medicine benefits are not taken into account in public healthcare systems, such as the one in Ecuador. So the 2008 Constitution, for example, guarantees the right to health for everyone in Ecuador, and this led to huge health reform with more infrastructure, the hiring of more health professionals, and of course the purchase of more medicines. This eventually also led to financial unsustainability, and this is why I'm tackling traditional medicine as an alternative to Western medicine problems in Ecuador. So I studied what are the perceptions people, especially the elite group, have about traditional medicine in Ecuador in two cities, Quito and Ibarra. And I studied the elite group, I would say, because they are the ones that are in power, they are the ones that are in government, and they are the ones that decide what kind of healthcare system we have in Ecuador. So also, it is important here to understand some of the background of traditional and Western medicine. Traditional medicine, on one hand, has been around the world for more than 60,000 years, while Western medicine has been only for 2,000 years. Traditional medicine concentrates on educating people, so it's basically 90% about educating people, and only 10%. And Western medicine is only 10% about educating people. For traditional medicine, consulting a health expert should only be made in 10% of the cases. And for Western medicine, they concentrate a lot on consulting health experts because they are the authorities. For traditional medicine, it is important to treat human body as a whole. It has a holistic view of body, mind, and spirit. But for Western medicine, it is important also only to treat the body part that is sick. Traditional medicine traces the root of health issues, and Western medicine treats only symptoms. Traditional medicine, it's very effective in health, in mental illnesses, and on the other hand, Western medicine has great technological advances to treat serious diseases and emergencies like traumas. Also, for traditional medicine, there are no sudden, inherited, or untreatable diseases, while for Western medicine, certain diseases can be sudden, inherited, or untreatable. So as I said, it is important to challenge these Western views of medicine. And here I listed some of the authors I reviewed that actually have challenged Western health medicine. For example, we have this book called Health and Culture Beyond the Western Paradigm, also Green Medicine Challenging the Assumptions of Conventional Healthcare, and a book from an Ecuadorian anthropology that is called What is Health and What is Disease. So there has been some people that have challenged this. So here's a little bit of the methodology I used here. I used semi-structured in-depth interviews with a snowball sample, and I analyzed my data with QDA minor. I had nearly 6 or basically 16 informants. They were from different ages, 18 and older, and they pertain to the high socioeconomic segment of the population, and almost all of them were highly educated. I use several social instruments or tools to analyze my data. First, I have constructivism, cultural and medical anthropology, critical race theory, and autoethnography tools also. But here we have the important part of the research, which are the results. So perceptions about traditional medicine are mainly the most, the perceptions that people mention a lot were that people from the countryside are the ones that use traditional medicine. So people who migrate from the countryside to cities actually lose their traditions, because in cities, people use Western medicine mostly. Also, people believe that it's mostly indigenous people, poor people, and uneducated people, the ones that use traditional medicine. And for some, traditional medicine, it's related to witchcraft. Therefore, it goes against the Catholic faith. There is also a strong view that traditional Western medicine are against one another. So for example, Western medicine is perceived to be easy and fast, while traditional medicine is perceived to be hard and long. Also, Western medicine is thought to be backed up by science, while traditional medicine, it's perceived to be a mere superstition. And also there was some interesting findings about medicinal plants, which are widely used in many countries in Latin America, also in Ecuador. And actually medicinal plants have become part of the Ecuadorian popular culture. Everyone uses medicinal plants. And I also asked informants about traditional healers. And for most of them, traditional healers are charlatans and they are dairy, although for some others also they are knowledgeable. So here I kind of analyze this data in more, this is a visual map of what I analyzed. So as you see, there is an iceberg of perceptions where you have things like traditional medicine use medicinal plants, or people who use traditional medicine come from the countryside, they are indigenous, they are poor, they are uneducated. But that's just the tip of the iceberg. However, there are many things that are underneath the water, like racism issues, education-based discrimination issues, classism, this dualistic view of traditional Western medicine. And at the bottom of all of it, it's Western thought. So we believe traditional medicine is not valuable because it's not backed up by science, because it's not modern, because it's hard, because it comes from indigenous people. So there are a lot of these thoughts that had been constructed by colonization, by Western thought. So here I put an example of how traditional medicine is perceived. If a traditional healer gives someone a plant for a headache or a stomachache, this person might not take it because it comes from a traditional healer. But if the same kind of plant, it's put in a pill and it's given by a doctor, then people would have a good perception of it, even if it is the same product. So this is the things that happened with our perceptions. So finally, as I said, there is a strong rejection towards traditional medicine, and there are underlying issues that are basically discriminatory issues. There is this dichotomy of traditional medicine and Western medicine. Also, Western thought is kind of the root cause of these erroneous perceptions about traditional medicine. And that is why it is important to deconstruct our erroneous perceptions about traditional medicines. This should be done in order to integrate traditional and Western medicine best practices. And this would in turn contribute to enhance the healthcare system in Ecuador and of course to improve Ecuadorians' health. Thank you very much.
Thank you, and we're on to our third and final presenter.
I'm just gonna share my screen.
I apologize, we have two more presenters.
All right, hi everyone, good afternoon. My name is Samantha Primiano. I am currently a doctoral candidate in the Department of Anthropology here at the University of Maryland. I'm excited to be here with all of you today and grateful that we've come together on Zoom as we have been doing on this Thursday afternoon to be in dialogue with one another. So these thoughts that I would like to share today are emerging from dissertation research on chronic illness in Havana, Cuba, that has actually been put on pause as we live in the midst of this ongoing pandemic. My presentation today is very much a work in progress, as it is my intention to sort of wrestle these thoughts into dissertation work. A year ago, a colleague and I boarded a plane headed to Havana, Cuba to present papers at the Society for Medical Anthropology's annual conference. At the time of our flight to Havana, there were no known cases of COVID-19 in Cuba, and in Maryland, the idea of global spread seemed like a distant possibility. Still, there were rumors that administrators at the University of Maryland were discussing moving classes online for the weeks following spring break, and concerns of border closures and canceled flights lingered in the back of my head. I remember moving through security, accepting a plastic bin from a TSA agent, and carefully placing my toiletries and technologies along the bottom. It would be the first of many instances in the coming year that I would pause to think about how many times an object had been handled, what had been left behind, and the potential threat that a previously innocuous item could pose. After moving through the line, I quickly grabbed my travel hand sanitizer dangling from the strap of my backpack, a visual icon of my effort to ward off the increasing threat of microscopic respiratory droplets. On the second day of the conference, in the midst of dropping into various panels and sessions, COVID-19 was declared a global pandemic. That my colleague and I were surrounded by global and public health experts at the time of the announcement seemed only to emphasize the dystopian feeling of this new pandemic reality, rather than provide comfort about this uncertain future. When I reflect on this time, I find those immediate days, weeks, and months following my return from Cuba to be hazy and indistinguishable from the quotidian of our current reality. I cannot remember the first time I put on a mask to enter a grocery store, nor the moments that I began to carry two sanitizers with me, one in my car and one in my purse, and store Clorox wipes when I could get them under the sink as if they were my most treasured possessions. Recently, in conversations with friends over Zoom, they noted that they find it shocking now to watch television shows or movies with scenes of maskless crowds and parties. It makes them uncomfortable, even claustrophobic. My friend's discomfort speaks to a phenomenon that I have come to consider as pandemic time, a temporality that is influenced by Lauren Berland's concept of lateral agency, where survival and life maintenance is agentive. Pandemic time is also inspired by Zoe Wool and Julie Livingston's innovative framework of the Collateral Afterworld. These are spaces or worlds where hopeful futures are uncertain, where acute problems become chronic, and where sociality is not an inherently positive force. With the concept of the collateral afterworld, Wool and Livingston seek to highlight how, quote, many people live not in spaces of vitality or in the face of imminent death, but in lasting zones of precariousness. This is a sentiment that is reflective of our current pandemic time. I first encountered the Collateral Afterworld as a framework for my dissertation proposal, in which I sought to understand the ways that those living with chronic illness in Cuba build lives and make do amidst economic instability and chronic resource shortages as an enduring result of Cuba's special period, a consequence of the collapse of the Soviet Union, as well as the compounding effect of the United States embargo against Cuba. During preliminary fieldwork over the summer of 2019, those I spoke with emphasized their frustrations about accessing certain medications, the high cost of soap and other hygiene products, and the infuriatingly inconsistent availability of toilet paper. When we would discuss these shortages, my friend Linda would frequently remind me over coffee and green tea, Samantha, necesitas entender esas cosas ocurren todo el tiempo, no hay, no hay. Samantha, you need to understand these things happen all the time, there isn't anything. She needed me to see that to move forward, to control her high blood pressure, and to take care of her family, she had to accept this instability as part of her daily reality. What I saw as an acute rupture in daily life, she had come to manage as a chronic condition. The COVID-19 pandemic has exacerbated these resource limitations. Cuba's economy fell by 11% due to restrictions on travel and tourism, as well as declining imports. Quarantine restrictions and shifts to online services have exacerbated unequal access to resources. Restrictions on public transportation limited people's ability to travel to different parts of the city where stores were more well-stocked. And the demand for products has extended already lengthy wait times to enter stores. In a blog post, Safi Gonzalez asks, ¿Dónde están los medicamentos en Cuba? Where's the medicine in Cuba? As she details the difficulties in accessing medications that those living with chronic illness are currently experiencing. Further disruptions have occurred in the pandemic year as the government reconfigures its two-currency monetary system, further exacerbating financial inequities, as artists and activists in the San Isidro movement protest and push for democracy, and most recently, the resignation of Raul Castro as head of the Communist Party that now leaves the country without Castro leadership for the first time since the beginning of the revolution. Instability and disruption abound routinely. Similarly, pandemic time in the United States has been marked by mundane disruptors as the acute becomes chronic and the stresses of infection, debt, eviction, and loss are intertwined with the everyday. It is a time in which people's livelihoods and well-beings are in the hands of narcissistic politicians and divided politics. Considered as a collateral afterworld, pandemic time is a temporal reality divorced from a sense of hope for a better future. This sense of futility is concretized as many struggle to envision a possible end to the ruptures created by the pandemic or conceive of their evolution. It is compounded by the fact that protests and efforts for social justice in the wake of the murders of Ahmaud Arbery, Breonna Taylor, and George Floyd were met with many further instances of political and police violence, as well as the enduring presence of Trumpism, despite the removal of Trump, reflective of the long and enduring legacies of white supremacy in the United States. In addition to reconsidering the temporal dimensions of crisis, Wool and Livingston, along with the contributors to the March 2017 issue of Social Text, call for the collateral afterworld to be a space in which the ambiguities of sociality are similarly investigated. The authors argue for taking the very notion of sociality as suspect, forcing us to consider and reconsider what the social actually does. As they adamantly note, this is not an inspection that leaves the social devoid of meaning. Rather, it demonstrates the multiplicity that is present in social relationships, that they can, on the one hand, provide meaningful emotional support, and on the other, quite literally be the cause of infection. Care as a social phenomenon is similarly vexed. In their recent article, Care in Trouble, Vincent Duclos and Tomas Sanchez Criado argue that care is, quote, vexed, multiple, and often contradictory. And we risk calcifying care by treating it as a, quote, placeholder for a shared desire for comfort and protection. When my colleague and I returned to Maryland after the SMA conference, We soon received word from our department that having traveled, we would be required to quarantine for 14 days, a recommendation that now seems instinctive even as the CDC has readjusted its self-isolation guidelines as we learn more about COVID-19 and the effectiveness of vaccines. With looming state border closures, my family and I quickly encountered how the concept of care and caring for loved ones, typically valuing closeness and proximity, could be transformed as a result of this airborne parasite. In the pandemic, care is affect, it is medicine, vaccine, social support, even self-love. However, in the context of COVID-19, caring is also a risk. This was exemplified by the devastating losses that resulted from birthday parties, graduation celebrations, and other forms of proximal social support over the past year. This intersection of care and risk is also highly moralized. Taking risk on behalf of loved ones is held up and celebrated, despite the potential threat of infection. For instance, many have praised the friends and neighbors in Havana who have waited in lines and crowds to pick up food and medicine for those who are elderly or living with chronic illness. Similarly, the risks assumed by healthcare professionals have branded hospital and care workers across the world as, quote, healthcare heroes. The riskiness of care in these scenarios is socially and morally deemed worthwhile. This moralization of risk and care is exemplified as well in the risk assumed by individuals signing up for vaccine trials. Cuba currently has 5 vaccine candidates in development, with 2 now in stage 3 trials. The desire to be vaccinated and of service to the development of these vaccines has produced hour-long waits outside of Havana-based clinics. Individuals eagerly hope to receive notification of their vaccination appointments, despite the risks that come from participating in scientific trials. Alternatively, behavior that is not viewed as being altruistic or connected to the essential care of others has been highly stigmatized or even villainized within the pandemic. Participating in risky behavior without the presumption of care, while prevalent, has largely been characterized as extremely negative and harmful. As we look to our current moment in the pandemic time, with the rollout of multiple effective vaccines in the United States and the development of viable vaccine candidates in Cuba, the relationship between care and risk will continue to evolve. Most importantly, this relationship will be essential to examine as predominantly vaccinated countries purport to have established an upcoming, quote, return to normalcy, even as other countries are now hardest hit by COVID-19. To conclude, I do not see the case for situating pandemic time within the framework of the Collateral Afterworld as being a defeatist position. Rather, it is a commitment to addressing the prolonged acute and chronic destabilizations and ruptures that have predated the coronavirus, been exacerbated during this time, and will continue to exist and impact the most vulnerable. How we come to socialize and to care for one another, or provide and receive biomedical care, will continue to transform within this global rupture of a pandemic. Young children are being raised to be attentive to touch and germs in a way that will likely shape them into adulthood. Sociality and the risks we are willing to take to care for one another have been forever impacted. Recently, a reviewer gave me feedback saying that focusing research on the pandemic is short-sighted. In response, I say that even with vaccines, the loss of life, layoffs, resource shortages, unstable housing, learning barriers, and long-term health complications experienced by so many will carry forward and continue to impact individuals' security, as well as their physical, emotional, and mental well-being. The ruptures created in this pandemic time are with us for the and foreseeable future. Adaptations to how we care within this afterworld are only just beginning. Thank you.
Thank you. And now our final presenter, Emilia Guevara.
Thank you. Esta vida nos consumió. This life devoured us. Transnational migration, Crip time, and community-based temporalities. My name is Emilia Guevara. I'm a PhD candidate in the Department of Anthropology here at Maryland. Thank you so much for having me today. On an intensely rainy and foggy morning in March, I was awakened by a muffled woman's voice coming from a rusty loudspeaker tied to a tree at the highest point in the rural community of San Martin, Hidalgo, where I was conducting anthropological fieldwork. Today, the speaker mournfully announced the death of a young 25-year-old woman I will call Susana. The speaker noted the time and place of the funeral mass, burial, and the reading of the rosary that would be held each evening for several days. Susana's funeral would take place on the Campo Santo, or the hilltop cemetery high above San Martin. Susana's childhood friend, Sonia, a fellow transnational migrant and chronic pain sufferer, came by to notify the family and told me how Susana had fallen ill. We sat together in the courtyard as I listened. Susana developed severe back and pelvic pain working as a temporary migrant crab worker on the eastern shore of Maryland. After several weeks of pain, she had made the journey to the closest clinic. Concerned with the symptoms Susana presented, the doctor quickly sent her to an oncologist, where she was diagnosed with early cervical cancer and quickly transferred to a major hospital in Baltimore, Maryland. Susana's treatment was covered by charity care, but incidentals were covered by her husband, Mateo, a seasonal farm worker from her hometown who worked in North Carolina during the migrant farm working season. However, the cancer spread and metastasized into her liver and abdomen, leaving her in agony. Susana continued treatments for about a year until they could no longer stave off her cancer. Susana's mental state and physical appearance changed drastically. Susana became embittered not only at her physical state, but at her loss of status as una trabajadora chingona, a badass working woman who was making her own way in life. At her funeral, her grandmother, mother, and sister stood by the gravesite, steely-eyed and stoic. The men next to them cried freely and blew into handkerchiefs. Susana's extended family members and friends looked on sadly. Sonia was initially surprised that Susana had deteriorated so quickly. She had hoped that by acting to find doctors and specialists, Susana would be able to extend her life, and if not defeat cancer, die more slowly. She told me that at the least she had hoped Susana would live because of her strong will, mental strength, coupled by the power of modern medicine. Sonia told me it was easier nowadays to care for all sorts of problemas crónicas, or chronic problems. We all have them, she told me. Susana's hard work in life, quick decline, and seemingly meaningless death made Sonia feel that her own life could easily end in tragedy and with no purpose. She told me, I honestly thought cancer would be controlled because I know some crónicas, so women with chronic pain that live with everything, even types of leukemia, cancer. They just take pills to maintain themselves while they work. I don't know what happened to her, to Susana. She just slowly wasted away into nothing. By the end, there will be little left for us. She sighed, looking upward at the gray sky. Esta vida nos consumió. Here, the migratory life has devoured Susana and everyone involved in the migration process. Moments like these recount the experiences of transnational migrant women who live and work under the auspices of the temporary United States H-2B visa program and their transnational social networks. For 8 months a year, many of these women labor as seasonal crab pickers in rural and isolated areas in Maryland's economic and culturally significant crab industries. Even with temporary legal status, the uncertainty surrounding the lives of women living and working in the US was very clear. In this paper, I draw on multi-sited ethnographic fieldwork that span Mexican origin and United States destination communities. I argue that the way migrant women understand the course of their chronic illness changes and is dependent on where they are when they experience moments of physical and mental distress. Within my work, I found that migrant individuals and their communities experience Crip time, a flexible approach to normative timeframes and embodiments. As Lugister, Ellen, and Vikstrom note, Crip and Crip time are analytical concepts that create an understanding of time that differs from the ableist time, a way to view the social construction of ability and productivity. The formerly pejorative term Crip has been reclaimed by disability community and academics as both a site of identification and academic inquiry. Robert McRuer's Crip approaches are concerned with the way disability is culturally located and how and why some bodies are normalized while others are pathologized. I argue that this unique way of experiencing time can also extend to social institutions and the communities in which migrants live, creating pockets of community-based temporalities. By exploring how these temporalities manifest themselves in both disruptive and generative ways, I identify how Crip time encompasses physical and social wearing out or slow death of individuals who are primed for debility and disability in sending migrant communities. This disability and debility follow a historical pattern of transnational migration that spans many generations. Viewing life through Crip time also reveals the engaged actions of communities and local institutions in response to precarious and chronically violent conditions of migration and labor. My larger ethnographic project connects the Eastern Shore of Maryland with Chapulhuacan, Hidalgo, and explores the relationship between transnational migrant women, labor migration, and chronic illness. In this larger project, I consider how the current biomedical concepts of acute and chronic categories and the biological progression of illness are dependent on cultural variability of prevention, causality, and accessibility of treatment. Maryland's Eastern Shore lies predominantly on the east side of the Chesapeake Bay and consists of 9 counties, Chapulhuacan, Hidalgo. Chapulhuacan, Hidalgo is one of 84 municipalities in central eastern Mexico. This larger ethnographic project provided valuable information about how chronic illness is present but not well understood, as well as the invisibility of suffering, which is exacerbated by labor and migration. For 14 months, I ethnographically chronicled the lives of transnational migrant women in their home and daily lives in rural Hidalgo and at work in the US, extracting crab meat from blue crabs or crab picking on Maryland's Eastern Shore. I accompanied medical providers in Mexico and migrant outreach clinics in the US. The clinics provided care to migrant women who lived in employer-provided housing on a chain of islands in the Chesapeake Bay. I also observed and spoke to the employers and owners of various crowd processing facilities in rural Maryland. I conducted in-depth interviews with 70 individuals in the migrants networks in the municipalities of Chapulhuacan and Dorchester County, Maryland. I observed the daily lives of the work of migrant women in their communities and abroad in the United States. I lived with and accompanied the women as they shopped, went to church, obtained medical services. I spoke to community health workers, physicians, clergy owners, and managers of crab houses and their US-born employees. In this way, I attend to migrant women's complex social and economic obligations, their kin relationships, community networks, and events that occurred in everyday life. During my stay in Chapulhuacan, I frequently purchased fresh fruit from a local man who had a small stand that was covered by a large blue tarp. We frequently talked about his travels to the US, as he had worked on both coasts in California and North Carolina for over a decade. Still a young man at 40, he looked tired and was very thin. He told me he could no longer work full time. His last job was picking tobacco, but after several seasons, he felt terrible and could barely eat. He told me, I was poisoned, and they even told me as much. I remember some of the training we had that a nurse had given us. They told us if we did not wear gloves and wear protective clothing, we could absorb as much nicotine as a full pack of cigarettes. I didn't take it that seriously. Yes, I protected myself as best I could. I didn't smoke, can't touch the garbage, but I feel nauseous to this day. It's been 3 years since I last worked in those fields. I'll probably get some sort of cancer. That's what the clinic told me. I just sit here watching my life passing me by. My family had to take care of me until I felt ready to work again. I'm not bringing much money, but at least I'm surviving. I interviewed one private doctor in the community who worked specifically for migrants who could afford his services. He spoke about the processes of migration and how they created enduring psychological trauma, knowing that the migrants' jobs were not guaranteed, and the suffering that people endured while working. Migrants had to at least appear in good health to make it to the US, and the moment they aged or began to show deterioration, they were no longer welcome.
5 minutes.
The doctor told me. These people are disposable. It's a machine that exists to take them, use them, and spit them out. They internalize and are dominated by the dream, everyone's dream, the American dream, the dollars. Because they see others arriving with bands, others arrive well-dressed, arrive with a lot of money, supposedly. But without knowing, they say, look, I've got this. And they don't tell them how they suffer to get everything they bring. Everything they see is dazzling. To the children, they see this, and instead of parents saying, no, because I want you to work with your brain, they continue this false dream, and it begins again. When they come home, they're husks, and they come home to die. This is what I see. A 20-year-old man I met who drove a taxi was the son of a migrant woman who migrated to Mexico City to work. She hoped to go to the US in the future and hoped the same for her son. The son told me, I'm waiting for my turn to go. In the meantime, I just sit in this taxi and wait for people to come so I can drive them where they need to go. I hope for the best, and I think it'll happen to me. I just have to stay still and wait. I know how to wait for a lot of things. A migrant woman I spent time with named Ellie had recently decided to end her career as a crab worker because her father was nearing 60 and had the physical age of someone in their 80s. He worked in the onion fields of Georgia for several decades and sent back money and kept the family out of poverty. She knew it was time to take care of him in person, and although she knew she would miss the income, she told me, it's time I took care of him. He did all of this for me, kept the family going by pushing his body to the limit. He had arthritis at 45, but kept going until he could barely move. It takes him several hours to get up in the morning. I wonder what kind of problems I'll have in the future. I will try to be healthy and prepare myself for these issues, but it might not matter. I've been volunteering at the local clinic here, and there are the nurses that tell me that they know anyone who comes back after being in the US will have different problems. In an interesting reversal, Mari, one of the H2B workers, came back for the new season and told me she was never sick in the United States when she worked, would come home ill, and would develop various respiratory infections, a common occurrence in an area with high humidity and cold temperatures, like the mountains of Hidalgo. I have asthma, she told me, but it's controlled while I'm working, even in the smelly crab house. I take my medications very carefully, whether at home in Mexico or in Maryland. I don't really know why. However, when I went to visit her at her home in Mexico, I had an interesting conversation with her daughter. She told me, because my mother worries, I think that's where the diseases begin. I feel like my mom gets sicker here in Mexico. She adapts to el otro lado, the US, and I listen to her. She talks to us on the phone. She listens well and she listens and is happy. Because of her entire day consists of work, she arrives at her house. There are no noises. There's no mess for her to clean up, no problems except those that her roommates have. But when she's in Mexico, it's the issue with the dog, the toys strewn everywhere. She's worried about crime, about us getting killed or getting in an accident. When she's in the US, where we're going, there's no need to worry. Within this example, it was clear that pocket temporalities of disability could disappear and reappear just as easily in the United States as in Mexico. The examples in this paper illustrate how I have identified cultural locations of disability and slow death within migrant communities of Hidalgo and the US. These are locales that represent a saturation point of context and disability, where physical and social wearing out of communities occur. While these saturation points are not immediately noticeable, over time, unique patterns emerged that indicated that every person who lived in the community, migrant or not, participated or had linkages to the migration process. Migrants, clinicians, and the families I spoke to were very concerned about what would happen to their communities when they were no longer productive, and life would eventually devour them. Thank you.
Thank you. We really appreciate these really thought-provoking presentations that are all very interconnected, and we're very excited about that. I'd like to invite everyone who's participating to please go ahead and type your questions in the Q&A. We do have a hand raised. I will give David Sartorius permission to talk. You should be able to talk now if you'd like. We can't hear you. I don't know if you're talking. That might have been a mistake. In the meantime, there's a question in the Q&A box right now. Clara Irazábal says, this is such a wonderful and cohesive set of presentations. Congratulations. Can you comment on each other's presentations? Any insights from them or recommendations to them that you can offer to each other? And anyone who wants to, I think you can you unmute yourself? Are you not able to unmute yourselves?
I think we can.
Oh, there we go. Wonderful.
I have a question, actually, Anna. I was thinking about sort of what, this as sort of the connection to Rupture and mental health services. Do you see, or how do you see the pandemic either being sort of a catalyst for change in calling for sort of a decolonized mental health approach, or how do you see sort of the impact of the pandemic, telehealth involved in that as well? Is there any sort of change that could sort of be brought about through this time?
That's a great question, Samantha. Because I am a current practitioner, I am in the world of practice, of seeing how the pandemic has radically just changed how we provide services. I mean, we're all doing telemental health at the moment with no word of going back to in-person unless it's like in dire need or there's reason why we have to do it. But primarily we're providing telemental health services, and it I guess creates a larger barrier for immigrants, Latinx immigrants, due to, like I mentioned, lack of access to computers, internet. The children are moved to school online, so maybe they do have one computer, but it needs to be passed around, moved in a family of a large family. So negotiating time with the internet is also an issue. So I've found that the more marginalized communities, Latinx included, are having a really harder time than normal right now with the pandemic accessing services. And in turn, the providers are being a lot more selective in who they provide services to, and which is not serving our Latinx community. So has it opened up space to do work around decolonization? The pandemic, unfortunately, I would argue no. If anything, it's made it harder due to some of these factors that I mentioned. However, I do have to say that I have witnessed the Black Lives Matter movement radically also shake institutions of mental health, and in turn push them towards more dialogue around these decolonizing principles that I mentioned. So that's a positive. Yeah, and so hopefully, we could learn how to, or create systems to better serve the Latinx communities within the pandemic, and using the momentum that we're having with this Black Lives Matter movement, if that makes sense.
It does. No, thank you for sharing, and
You're welcome.
It's very, very thoughtful.
Other thoughts or comments for each other? I personally was interested, I know it may not affect all of your presentations equally, but I was thinking a lot about how scholarship impacts these relationships that you're seeing in these communities, and wondering to what extent you think that scholarly interventions might sort of reproduce some imbalances of power. I'll give you a more specific the example that came to my mind when I was listening to Ana and Valeria's talks is I've been asked, I speak some Quechua and have been asked to interpret in a medical context. And the question that the healthcare provider asked was, you know, this old woman sleeps in the same bedroom as her adult children. Is that okay? And so asking me to be interpreter in a very inappropriate kind of, you know, sort of a cultural interpreter. And I said, that's totally normal. But I felt that it was sort of asking me to validate a practice, right? So I'm wondering about that. Where does the outside expertise become helpful, and what are the limits of that in what you've found?
I could attempt to answer that, Lisa, Valeria, if that's okay with you. I can start. So interpreters in the large hospital system I work with, interpreters serve a huge role, right? Primarily the practitioners do not speak Spanish or Quechua or American Sign Language, which is also very important, and require the need of interpreters. And there's large conversations happening in the practice world, how interpreters may end up complicating treatment and actually just be more of a barrier than helpful, right? So much so that I've also witnessed, which is not good practice, I would say. Many institutions shy away from providing services to individuals who are not native English speakers, or if they don't have a practitioner who speaks the native tongue of the individuals, they often, you know, the referral process out. So I believe, I mean, training, there's a lot of training that needs to be done in collaboration with interpreters. That will facilitate access, right, to our Latinx communities or marginalized communities. A lot of conversations need to be had with this culture of also evidence-based, like manualism. What I'm arguing was having the flexibility, right, of incorporating culture into conversation and allowing space for the interpreters to facilitate some of that could be something we could explore as a potential answer to this. That, you know, that could be a good start, but I believe that interpreters are key or assets, could be assets given the right systems of support around them to face this issue, this crisis, the mental health crisis.
Yeah, I would also like to say something about it because, as Anna said, sometimes interpreters can be actually a barrier. And actually, for example, cultural competence can be understood as simply interpreting or just translating from one language to another. But other than language, I believe culture is a central thing there, because not many doctors are actually open to any other type of knowledge, like I said, traditional knowledge or alternative knowledge. So basically, they just assume everything. It's has to be Western medicine, and that's the only valid point of view. So whenever people do anything else, they regard it as not valid. And that's not always true. It might be, but the problem is that they never really take into account that there might be other realities, other ways to treat the same things. So they are not, I would say, culturally open to understand other points of view. And that for me it's more of like the root cause of that particular problem, other than language itself.
I think answering, kind of talking about, as an anthropologist, I'm kind of both a foot in, a foot out. I'm actually a native Spanish speaker. My family's from Mexico and Venezuela. So actually, but my family's from Mexico City. So again, I have a kind of different perspective. It's an urban kind of American also perspective, but in the communities in which I lived, it was, I listened and watched kind of the everyday to understand, what had value for people. And although I do have a little bit of training in public health, and I did, meet with clinics and doctors to understand like kind of their perspective on migration and chronic illness, it was the words of people themselves that allows me to interpret what is actually happening in the communities. So I think, that was basically key for me to just be quiet and pay attention. And, so a lot of these kind of, and for me, like interpreting themes and kind of ideas that kind of people bring forth in their, in the many, many conversations I had, in church over some coffee, in the clinic itself. So I, take special care to accurately portray these individual, kind of opinions and discussions.
Yeah,
Yeah. I would. Oh, go ahead.
I don't have the necessarily speaking from a clinical setting or, but in terms of sort of the way that anthropologists in my studies have been battling with how to sort of interpret at the structural level without diminishing agency, I think becomes sort of the continuous battle, particularly with the Collateral Afterworld, which sort of does have this sort of very defeatist mentality to it. And so sort of how you engage with that, the theory without sort of, as Emilia was saying, diminishing the stories and the experiences, I think is the sort of eternal struggle. And I will say that in practicing sort of ethnography from afar and starting to do more of this discourse analysis, my attention to linguistics, to reading has shifted, especially in the way that different media sources are covering the development of Cuba's vaccines, the sort of coded language, the thing that's like come up sort of repeatedly in terms of justifying the development and the scientific rigor and all of these sort of read between the lines moments. So I will say that that understanding the way that people are writing has become even more important as I sort of engage this project in the pandemic pause.
Thank you all. I have 2 questions, and please, if you're watching, feel free to type your questions in the Q&A box, or we can also take some from the chat if you want to send them to me. The question is, can you reflect on how you hope that what you have come to know through research informs your professional or academic personas moving forward? In other words, your way of teaching.
I could share that because I also teach master level clinical social workers. I could share that my research has really allowed me to be comfortable with this idea of not knowing, right? And understanding the complexities of the individual and how complex culture is, right? And moving away from this idea of cultural competence, being an expert over a culture or an individual, to understanding that level of expertise is never obtained. It's an ongoing process, and it's okay, right? Maintaining that humility. Emilia, I believe that term is more from your profession, and very recently mental health practitioners are using it. But have the humility to say, I don't know, right? And ask questions, or this is new to me. Really kind of going away from more Western idea, but I am the expert, therefore I know to, can you inform me, right? And again, this idea of more relational work, partnership. So really trying to have those conversations with current practitioners, but also individuals that are entering the field and building that level of comfort to not know, and that's okay, right? That's what I would say.
In my classes, if I can just step in, so very much what I was saying earlier about, you know, listening to people. I think this is very much so in kind of my burgeoning pedagogy. Like I'm, you know, have taught one class, been a TA for many years. You know, the experiences of the classroom or the students, can inform the way you teach. In actually listening to what kind of really interests them about what you're saying. I think that's basically the key element. The research itself has allowed me to be very thoughtful and very kind of focused on details that may not matter to some, but ultimately it tells you a little bit more about how people think. And so I think that is very helpful to be able to see the kind of the minutia of daily life, and then like showing it or understanding how students, they have very important things to contribute. I think as a student myself, sometimes you felt like you couldn't, what you said didn't matter, but there's a lot of thought and a lot of experience in students.
I would just add that I think I feel more, I guess, more and more uncomfortable as I've moved through my studies thinking of myself as an expert in anything. Like, I know it's trite, but the idea of like, the more you start learning, the more you realize how much you don't know, feels very apt. But I think one of the things that I've learned from my discipline is the importance of empathy. And as an educator, and someone who's trying to hone pedagogy in this space, I think paying attention to the student and the whole student is incredibly important in understanding that they are existing in this class as well as in the context of a university and context of their lives outside of school, that this is 1 hour or 2 hours that you see them in the context of their entire lives. And so I think for me, that has been sort of the biggest contribution to the way I approach teaching, is that you have to see and engage with your students as people, at the very, very fore.
I don't teach, so I don't know if I have an answer for that, but for my personal life, I believe traditional medicine has helped me a lot, because traditional medicine has this view of not just treating a symptom or just taking care of an illness when it comes, but to live a healthy life, to not only eat healthy or exercise, but also have healthy relationships, have a healthy relationship with communities, with nature. So it's a very holistic approach that has helped me personally, and that I think that's a lot.
Thank you. So I have a question for Samantha that was sent to me in a direct message. It said, given that different countries are experiencing different waves of COVID-19, do you get a sense from your research that people are experiencing multiple temporalities of pandemic time and multiple temporalities of care? If so, how have you seen this manifest?
I think that's a great question. I've been thinking a lot about that in the way that waves are occurring globally. I don't know that I could speak to it on a global scale, but what I would say in the context of the United States, and even Cuba would be the sentiment, right, of sort of apathy and frustration of being within the context of pandemic time, I think has sort of ebbed and flowed in particular ways. And so the ability, I think, the ability to care for others and sort of think in that context has also then ebbed and flowed with everyone's reactions to the pandemic. I think vaccines are an interesting factor in this, and one of the things that I sort of wanted to put in the presentation but don't really know yet what to make of it is sort of what comes from care in those after we've been vaccinated, as we start understanding what sort of the parameters are for engaging with sociality in this new way. How does risk come into play in those cases, as we start to learn more about variants and how we'll be impacted, even if we'll need boosters. So I think there's far more to come as this question points out in terms of temporalities, whether they're emergent or consistent. I think I would argue that they're probably emergent in a way that I have yet to fully understand, and I'm sure we'll continue learning. And thank you for the question.
Thank you. We have time for one or two more questions if anyone would like to raise their hand or type in the chat. And of course, if our panelists have questions for each other.
Valeria, I have a question about the sort of intersection of biomedicine and alternative medicine, and sort of how those who are engaging in both or traditional medicine sort of make sense of the connections or the conflicts or the intersections between the two, or if you've had any data on that.
If there is like somewhere where they actually integrate them both, that was the question. Yeah, so there are certain countries, especially the one that I studied in Latin America, it's Bolivia. They do have certain cases, and also a lot in China. But in Bolivia, there is this, and also in Ecuador, there is a specific case where you can go to a hospital and they do not only offer Western medicine, but also traditional medicine, indigenous medicine in Ecuador. So you can choose whether to, I don't know, if you are going to give birth, to use a doctor or a gynecologist, or to use a partera. So you can choose between those two. But my idea actually was not only to make this thing that is coexist for me, because they do coexist in certain places, but to integrate, which is just take, like, there is good things here from traditional medicine, there is good things here from Western medicine. Shouldn't we just integrate them both and make like one system that it's the best of the both? But right now, what we have that is actually the best thing we have is coexistence in certain places.
Thank you.
You're welcome.
I think we've had a really long and productive discussion, and I'd like to thank all of our panelists for your really interesting talks, and invite the audience to return. We're going to now take a break until 4:15, when we will have the panel Migration as a Form of Education and the Transfer of Ideas in the Present Day Americas. So thanks for joining us. Hope you will be back if you need to run and take a break right now, and we'll be right here on the same Zoom link.
Thank you so much.
Thank you,
Everyone.
Thank you.